panel, and the moderator. The panel discussion will be on how meaningful data can improve patient care journey, as well as support healthcare professionals every day, and to improve the quality of service. This discussion will be moderated by Valts Abols, and Valts is the chairman of the board at the Children's Clinical University Hospital in Latvia. Valts serves as a CEO of the named hospital. He's also pioneering the data used to enhance patient care and health outcomes, and he wishes for the Children's University Hospital to be the first hospital in the Baltics, Children's University Hospital is the first hospital in Baltic region to introduce a unique electronic, real-time, patient-reported experience measurement system. Valts' ambition is to build a digitally enabled, integrated children health ecosystem that embraces all children, their families, health professionals and caregivers with the common aim to improve children's health and help them to realize their full potential. Let's welcome Valts on the stage. He's going to take my place at the moderating table. We're also going to invite on the stage Baiba Ziemele. And Baiba is a board member of World Federation of Hemophilia and the president of Latvian Alliance of Rare Diseases. By passionately learning and gaining experience from an ordinary patient, Baiba Ziemele has become a patient advocate in Latvia and internationally. She addresses various issues related to healthcare and access to medicines for people with bleeding disorders, including hemophilia, von Willebrand disease, rare coagulation factor deficiencies, and others. People with rare diseases and patients in general. Baiba, welcome. The panel will also be joined by Ain Aaviksoo, who is the general manager of Guardtime Estonia, and who prior to this worked as an undersecretary for e-services and innovation for Estonian government, overseeing the digital transformation and innovation of healthcare, labor, and social markets. Dr. Aaviksoo has published over 20 peer-reviewed articles and contributed into several book chapters on health policy and e-health. Dr. Aaviksoo will join us online. Hello. The panel will also be joined by Walter Ricciardi, who is a chair of the EU Cancer Mission and a professor of hygiene and public health in the Catholic University of the Sacred Heart. He's also the scientific advisor to the Italian Minister of Health for coronavirus pandemic. He is the scientific director of ICS Maugetti, president of WFPAJ and the Mission Board for Cancer, and coordinator of SAB of Human Technopole Foundation. And he's the former president of Italian National Institute of Health. Hello, Walter.
Hello.
The panel will also be joined by Erik Forsberg, who is a PhD and associate professor and managing director at EIT Health Scandinavia. Erik is the managing director of the named organization and a member of EIT Health European Management Board. He's also an associate professor at the medical faculty of Uppsala University in Sweden, and he has a deep experience of managing various non-for-profit organizations and public-private networks. Hello, Erik.
Hello.
And here on the spot, the panel will also be joined by Emil Syundyukov, who's a co-founder of a company called Longgenesis, based here in Riga, and he's also a computer scientist dedicated to healthcare and education. Emil has 8 years of experience in applied research in industrial solutions development in healthcare around the globe. He received multiple academic and industrial awards, including EIT Health, GAP Summit from Cambridge University, Young Scientist of the Year in 2016, and Baltic Forbes 30 Under 30 nomination in healthcare and research. Emil, we welcome you on the stage. And Walt, the floor is yours.
Thank you. So, hello everyone. I'm very honored, in fact, to moderate this session with such a distinguished panelists, everybody coming from a different field and presenting a very different expertise. I do not regard myself as a data expert, and that's give me advantage of asking every silly question which comes up to my mind, and nobody will blame that for me. So data analysis has changed the way we look at the data, and the reason why we collect the data across the industries. And healthcare is not any different. So healthcare data analysis nowadays help us to improve the patient outcomes, to predict diseases, to prevent outbreaks of diseases, and potentially also reduce the costs. We also know that average human lifespan is increasing across the globe. And that poses another challenge of how we will deliver the healthcare in the near future. So health professionals, just like many other industries, are collecting massive amounts of data. And the biggest question is, can we use them in a best way to build a better system and to serve the patients better? So now I will kick off as a warm-up, and I'd like to ask one lightning question very briefly. Please, every one of you in the panel, name 2 to 3 main arguments from your perspective why you personally believe that improvement in data availability and analytical capacity will benefit the patient. So I will start with Baiva, probably as the only lady in our panel.
So I identified 3 things. I think one of them is less paperwork, because now everyone carries around, like we heard already in the morning, everyone has lots of papers to carry around to prove some kind of things that are happening to their health. Less misunderstandings, because then we don't have to use our memory to repeat to doctors something that we don't understand completely, and also less waste, not only for the patients, but also for the governments in terms of spending, because you have to pay for the services you provide to people, and if you can't manage the feedback of how it works, then it doesn't matter.
Okay, thanks. Should I continue then with Samuel, who is also here on the stage?
Sure. So I'm a computer scientist, but during the panel discussion, I would like to be less technical. So basically, before we start, diving into a variety of analytical added value that we can bring, in applying AI or any other technologies, I think the first benefit is showing the tangible added value and in the process of receiving healthcare. So once, as an example of Stanford, when a patient arrives to the emergency room and the doctor runs to the other clinic to check where is the laboratory examination of the data, once we eliminate this and show the exact result that healthcare process happen faster, more secure, with added value to the patients and to the doctor, then we can proceed to the second improvement, in my opinion, when and if we will be speaking about putting the patient-centric and proactive engagement of the patient to the process of data access and data analytics, then also the freedom to operate, freedom to communicate with patients across other countries, not only within our small country, and also receiving access to newest diagnostics, newest treatment opportunities. So that's...
Okay. Thanks. That was a very comprehensive answer. Thank you for that. So, Walter, if I may ask you, what are your thoughts on this?
In Europe, we have to find a balance between data sharing and availability and privacy protection. And as Mission Board member, we have made a plea to the European Parliament to modify the GDPR, because currently that doesn't allow to do that. And the third challenge is the cultural change. I mean, we have technological challenge, but the most important is to train the old and the new generation of scientists, professionals, and also citizens to manage the transformation of this. And these are 3 challenges that, unless overcome, is going to be very difficult in Europe to do that.
Okay, so we also have challenges. So Eric, what are your thoughts on this?
Yeah, because I'm more on a managing director for managing partnerships between the public and the private sector. I would also want to point out especially then the need for companies who strive for more close collaborations with the healthcare system, including the data, that we can find more better improved model for public-private partnerships to share data, to use data in a secure manner, an efficient manner, and that will drive the implementation of systems, products, and eventually benefit patients. So I would like to point out that one, sharing of data in an efficient manner in public-private sector.
Okay. Thanks, Eric. And finally, Ain, What would you contribute to these points?
Thank you. I'm being trained as a medical doctor, but then also being a data nerd since the early days. So my thinking is that healthcare first is all about making decisions. And good decisions are based on data analysis and information. And actually, I do like the question a lot because it combines two critical components that, in my view, cannot be separated. More data only adds value if better analytical capacity is applied to it. Otherwise, it will be just a lot of data noise, and vice versa. Analysis based on poor data is just illusion of informed decisions. So yes, I think that it will create a virtuous cycle for patients' health if you start making good use of reliable data, as the data only gets better if put into use through meaningful analysis.
Okay, thanks. And that leads us to the next discussion with the more individualized questions. So we already heard from a previous speaker, Professor Verghese, on the importance to balance technology drive with the agenda of the patient. And I personally believe that healthcare data analytics are only valuable if they, by some means, really serve the patient. And we have many unresolved issues in our health system, and the silos of those data is one of them. We already heard like patient story in the opening of this conference, but building on that, we know that we collect bits and bytes of healthcare information, and then we archive it in different places, in hospitals, in primary care offices, in outpatient clinics, you name it. And that prevents really the integration of patient pathway, and basically it fragments all of the patient care. And I would like to know how BIBA feels about that, looking or standing in a patient's shoes, and what are your thoughts from a patient perspective, how good we are in a data utilization for a patient benefit?
I think I have to first say that long gone are the times when we were the patient as in the picture, lying in the bed and relying on doctors' intuition on how to treat us. Because at 2 centuries later, we are here, we are patients, we are very professional people who can hold discussions with all stakeholders in the field. It's not just Latvia, it's beyond, it's Europe, the world, and I think the creation of partnerships is something that we can do to overcome all the obstacles that we have at the moment. For example, like I said before, all the waste of time and other resources in the healthcare, we don't have so much money to spend on various things that are not necessary. But I also think that true patient centricity is something that we still are learning. For example, you can't just invite people to tell their sad stories in conferences. You have to invite us already when you start doing analysis of what is missing in the healthcare system, and because we are the ones who are receiving the care. We work with doctors, we work with everyone, and we can with all the experience we have from different fields, because the patient, it's not an isolated subject. We all have our families, we all have our history, we come from somewhere, and we all have some experiences that we can use to help patients at larger scale. And therefore, I think one of the things that we already miss in the system is that we can't analyze how much we have spent. For example, for hemophilia patients in Latvia, we spend approximately 4 million euros a year. But can we count how many annual bleeds have we saved? No, because we don't have systems like that. I come from a field with the rare diseases. This means that these patients need very specific care, which is basically because of their special diseases. And I really, for past 10 years, I have been begging and crying and doing everything I can to make, like for me, I'm not a data scientist as well, but I think it should be very easy to create a flag or something in hospital system for the patient, so that when I come to the doctor, then he sees, for example, I have a bleeding disorder, I can't take aspirin, and it should be already in my medical records, and there should be no questions about it. Like you just open my file and everything you can see there. And I think it's so easy to create small changes that make big impact already in the system. Yeah.
Thanks for that answer, and that's very well leads to my next question. You mentioned also patient centricity, and I'm completely confident that every single patient is looking to achieve the best treatment outcome possible. There is still much to be learned about the outcomes in the cancer treatments. But from the patient perspective, one would always want to know how many people in the real life setting have experienced some adverse event or achieved the desired treatment outcome in particular time period. Yeah. This apparently simple question could only be answered currently by going to the many places, looking in many files in different locations. In reality, it might not be even feasible. So therefore, my question will go to Walter. What could data from disease registers, like cancer register, bring to perspective of better treatment outcomes and research outlook?
In the board, we would like to go beyond the concept of cancer registries, which of course is very important, but I couldn't agree more. In the health sector, we are lagging behind. All too many observations lie isolated and forgotten on personal hard drives and CDs, trapped by technical, legal, and cultural barriers. And so we are going to propose something incredibly new, something which is disruptive, the European Cancer Patient Digital Center. So it's a virtual network of data infrastructures where patients can deposit their health data. Patients will have full control over their own data. They will have a health passport with personalized recommendation for the best treatment, and will be a source for patients and families of validated information about their cancer. Of course, there are problems. As I said, we need to change the GDPR because the governance has to be based on patient-driven and, of course, has to be containing expertise in data mining. But we have to investigate what is the role of patients in governance, what are the necessary technical and legal infrastructures, how to ensure that patients feel safe to share their data, to set up at member states tailored procedures to trigger data release from hospital by patients, and to support research that answers the needs of cancer patients. But if we do that, we bridge the gap with other sectors. We can create a data center where patients will have full control of their own data, where data will not only be for the use of researchers, but also for the use of patients. And this is the next step we need to take to help realize the full potential of real-world evidence and the step that can make the difference in outcome of cancer treatment. This is not easy to do. There is a lot of work, political, cultural, technological. Maybe we have to speak and to engage with the European Parliament to do that, but we are doing that. But if we work all together, we can do that.
So many thanks for that encouragement and outlook. But we know that there's still a lot of unmet need in a healthcare, and therefore speeding up research process would accelerate that course towards the more advanced treatment and diagnostic options. And that research happens through the number of clinical trials. And therefore my question will go to Emil now. So how can data help to connect the ends by finding the right patient for the right trial at the shortest possible time? And how to drive more research based on real patient needs?
Okay, that's a very interesting question. Thanks a lot for that. So as far as you already elaborated, so the key to finding new therapies and access, especially for the small countries, when we need to look, across the borders and see what are the typical new findings in the therapies or rehabilitation treatment procedures and apply them to local patients, is connecting the dots and connecting the stakeholders. But before, there is tech for that, and we should treat the technology as a screwdriver, basically as a tool to solve the problems. But beforehand, and I think everyone today elaborate on this topic, we should find what's the motivation, what's the added value for each of the stakeholders represented on the stakeholders map is. What is the added value for the patient, not just stating to the patient who actually needs an added value now that sharing the data will benefit to the future generations, so on. That's a very good thing, but we should step the layer down and think about what the patient can receive now. as an added value, from sharing his data, from controlling who, why, for what purposes uses this data. And also in parallel with that, the clinical investigators who are, connecting the dots between the patients and the industry, both scientific and biopharma, we should also dive deeper into why they would use the registries, why they would use the IT systems to benefit, why they will input this data, not just for the sake of structuring the data for the future generations once again. Because I think Professor Verghese already elaborated that they have this, too much things to do as a physicians. And why don't they need to use, another system just to type the data in for the sake of, future something, but they need to understand the added value, whether modernization, whether scientific excellence, and also better care for the patients. And there are examples of that. Just the last question, I know that time is very hectic today, that my group worked in an APAC region and in a Middle East region when we provide the personalized health program for the governments, when patients and the donors not only go to the clinical institution and donate the biosamples or donate the data, but also receive an access to the framework where they can see all of the requests coming from different scientific groups stating, hey, you have a risk of CVD or cancer or any other disease, or you are a patient, we would like to engage you, we would like to use your data for the sake of the research A, B, and C. And then, the patient also controls who uses the data, but the legislation framework in the regions applied that the ecosystem and the groups coming to use the data should also leave the added value from the scientific findings to the healthcare ecosystem in the country itself. And I think we should move towards that, towards right communication, plus also the legislation making it attractive to the industry coming here, and also leaving the added value right now to the stakeholders involved.
And that's already happening now. I know your company is also engaged in these kind of activities.
We're doing this in the regions, yeah. We're doing this in the APAC region in the Middle East, and running a couple of case studies already. With COVID research, we're doing similar stuff now in Europe.
Great to hear that. So those partnerships are very, very essential. And I believe our academic hospitals, universities, research institutions are ready to invest all available resources to approach the best solutions. But however, with resources we have, it's sometimes not enough, and we need really to join forces to reach our common ambitions. To take the meaningful advancements, really all stakeholders need to have a common agenda. And my question will go now to Eric. Eric, what, in your experience, also from perspective of EIT Health, what is experience in engaging the public and private actors? That's question number one. And then, if you can build on that, can you give us concrete examples of any substantial projects which have been introduced by data-based decision-making as a key?
Yes, of course, I will. The first part of the question is that we, in the innovation partnerships that we are working in, the critical engagement from the healthcare sector it's critical and often coming in too late, I would say. So more efficient partnerships is very important. And I mean, in pandemic times like this, it's of course very easy to understand why the healthcare sector cannot prioritize longer-term projects like we work with. But that is a key to engage the healthcare sector early on in projects. And if I would like to exemplify, according to your question, then I should start maybe with the event moderator, actually, Christas Krafte, because he have within EIT Health driven a company called Vigo Health. I won't go into that, but it's developing digital therapies for stroke recovery and using evidence-based tools and AI. So that's a very interesting example, but he will tell about that later, I think. I would like to exemplify with another project that it's very concrete, and it was striking to me as a generalist in this field to see how it developed. And it's called the Stockholm 3 test. And then a company called Onco Algorithm. And so you can just look at Stockholm 3 and you will find all information about that. This is about improved diagnostics and treatment of prostate cancer. And what they have come up with is a new test which finds the double amount of aggressive tumors. It reduces unnecessary therapies or biopsies. and also reduces healthcare costs. And this have been tested now in the Nordic countries especially, but also in other countries on some 70, 80,000 patients. And you can go in and have the test because it's available today, I think in Sweden, Norway, Finland, and Denmark. So this is a very good example. But then what came out, then it was published, I think, in Cell close to 2 years ago, was that they then had gone on and started, because the pathology is a very important part of this, the clinical data, because the whole test is based on proteomics, genomic markers, and genetic markers, but also on clinical data, and pathology is very important. So what they could show, and this was striking to me 1.5 years ago or so, that was that an AI system that they developed was as efficient in identifying and grading as world-leading uropathologists were. And to a person like me, that was striking to see. And not so long after that, they also launched a company called OncoWatch, where they developed these kind of products to automate image analysis and predict and assign Gleason scores. And it seems to be very, very efficient, actually. You have to search for pathologists, competing with what this is doing. So that is for me striking what it can do. But then, of course, the experts here in the panel can also describe cautions when it comes to using AI then. Will it do what it's supposed to do? How will it be personal? And so on. What if it goes wrong? Whose fault is it? And these kind of things. But this was a very interesting example for me, I think, seeing this.
Mm-hmm. Thanks, Eric. That's really a great example, but initiatives like those can only happen if there is enough support from the population, from the patients, and from people ready to share their data. And it's obvious that we can't engage patients against their will or without their consent. And we know that many calls for action or initiatives fail or have very weak uptake if the communication has been insufficient. And there is not enough understanding from a population side or the patient side why to share the data, what will happen to the data, who will have an access, for what benefit it's shared, and what control the patient will have. I would like to pose a question to Ain with the reason that Estonia is quite often mentioned as a country with very, very strong ambitions in a genomic analysis field, and also strong support from a population and the public. So Ain, you have that great experience in Estonia, and what drives the patient readiness to share their data for a common good?
Thank you. Yes, it is true. And I would start by making a statement that it has been a journey. So the trust is earned over time. It didn't land in Estonia miraculously. We have experienced 20 years of transparent, open information society, not just in healthcare, but also in healthcare, where data has been freely, but on a patient-controlled manner available to all healthcare providers for the last 13 years. And the pleasant experience of value-adding services added one at a time lets people to get used to the new reality, exactly as Baiva asked for just a few minutes ago. Making care summary records open to patients as well as doctors everywhere, introducing e-prescription, linking healthcare certificate for driver's license into a service between two agencies, Healthcare Information System and Road Authority, to enable fully digital renewal process where you can do everything from the comfort of your home, because that is a service for healthy people. And always keep the security as your highest priority. There has been not a single data breach from technical reasons from the National Health Information System. Yes, in early years, individual doctors and nurses were caught from peeking into the files. They didn't have authorization. They lost their job or license and were charged in criminal trial. By today, everyone in Estonia knows that in the digital domain, no act will remain unnoticed. Effectively, every citizen in Estonia is controlling the activity of the system participants as if they will know who and when did access the data. So no government agency alone could practice such an effective control. I was able to introduce personalized medicine program where on one's the genetic information will be made available for machine learning and clinical decision support solutions in primary care, only because the Estonian Genome Foundation, together with the rest of the Estonian healthcare system, has persistently built trust over 15 years. Do you know that when Genome Foundation started in 2001, only 16% of people supported the idea? The majority of the people couldn't just decide, they didn't know what it is. So one could have said that you cannot start with such a sensitive topic with just 16% of support. Well, Estonia chose another alternative path by laying the most progressive legal framework, implementing the best-in-class IT and taking risk-only baby steps. Over 15 years, the support has now grown to 85%. We wouldn't have reached here if we wouldn't have started in the first place. So yeah, just to finish up, in the initial setup, the genomic data and health data could only be linked in a totally offline manner to avoid even theoretical breach of the data. Only today we can talk about integrated services where genetic information and health data can be processed by machines using state-of-the-art cryptographic tools, such as KSI blockchain, to protect the privacy.
Thanks, Ryan. That was impressive. From 16 to 85% support. That's really impressive. So may I ask additional question? So who were communicators? Who were the ones who were convincing the population, people to support this?
It's an effort that everybody needs to be on board. So if doctors don't trust the system, the government can pour millions in public campaigns and nothing really works. That I think that the consensus in the Estonian society that digital services help everyone has been maintained over a long period of time. So I think that's something that maybe social scientists will discover at some point how did we reach that. There are many reasons for that, but most certainly doctors need to be on board. The government needs to work not to run over, take time if it takes, if it is needed to convince all the stakeholders.
Okay, thanks. And how does it look from a patient perspective, Baiba? I would ask you, like a build up on a previous question, how ready the patients are to share their data? And are rare disease patients concerned that GDPR limit their opportunities to access the best care or to participate in clinical research? And finally, are patients concerned about their data security issues?
So many questions, thank you.
But it's a session about the patients.
I'll start with this, the one that I think like it is a general one, because it's about the society. I have a feeling that we have huge gap in the knowledge and understanding of what is what, and the ones that are ahead of us, these people are running far away, and then there are some people who live in the countryside who have no understanding of what all these fancy topics we are talking about here. And I think we need something to make these people talk. Like you said in the beginning, that many things are happening in silos, and that shouldn't be the reality today in Europe and in the world. And I think that if we could somehow make these people talk and create the registries and everything else that is meant for patients, then it would be a totally different world we are living today. And to answer your question, yes, we rare disease patients are very ready to share our data. A few days ago, Eurordis, which is our European rare disease organization, has published a research saying that actually 100% of all patients, approximately more than 2,000 people from 66 countries have said that they are willing to share their data if it helps to find the cure for their diseases. And 90% of these people said that they are ready to share very private data to investigators to understand how biologics and everything happens in this disease. But also 80% of people said that we want to be in control of this data. We want to know who exactly has accessed the data and for what reason, because otherwise there is this old mistrust among all parties in the field that probably somebody will take my data and sell them maybe to the insurance companies. And what then? Like, why should I sacrifice some of my precious health data to companies? Like, not all patients are ready to sacrifice something big for the sake of the cure. Like some patients like me, we stand on stage and say, revealed our diseases, how we live with it, but not everyone is ready for that. Therefore, we even can't create forums in which we can teach patients about GDPR and other issues, because these patients, they want to be alone and they want to be left alone in many cases just because they don't want anyone to know about their health status. And that is something that we have to overcome. And I also want to say that sometimes I have a feeling that we patient experts and patient organizations have more knowledge about GDPR than other stakeholders, because we have had many cases when we request some data, for example, statistics from National Health Service, and they say they can't provide us statistics of how many patients we have in Latvia because this is personal data. Like, this is not personal data, this is statistics. You have law and you are obliged to gather data like that. So I think we have like many small pieces to this puzzle that we have to match somehow to create new realities for patients.
Okay, so and I think it's great to hear that you're really ready to contribute and the patients are ready to contribute. Now we switch gears a bit and move to another hot topic, and that's genomics. Genomics is the fastest growing technology invented so far, and genomic data have grown massively. So costs of this technology is decreasing constantly, and access is constantly increasing. So it's really a great boost, not only to research, but also to the clinical practice. So genomic studies are increasing not only in size, but also in scope. And last few years has been really the game changer. Many biobanks already store that much data to be able to accurately predict the risks. So my question will go to Walter. What recommendations regarding the genome data analysis have you included in the interim cancer mission report? What kind of collaborations we need to establish, and what we should not miss on a national level as a country?
Yeah, we have recommended the European Commission to develop a EU-wide research program to identify polygenic risk scores. And these actions aim to assess the individual cancer risk with refined algorithms based on newly identified polygenic risk scores. It's going to be based on an increased understanding of individual cancer risk, education activities, and counseling to be improved, exactly in the direction that the previous speaker said. Sampling and data collection would be harmonized to enable sharing on an existing European research infrastructure, such as BBMRI ERIC, IATRIS ERIC, Elixir, and the proposed program would foster the implementation of genomic and infrastructures, of course, again, compliant with GDPR, who has to be changed for data collection and dissemination, and taking advantage of different initiatives at European level, such as Digital Health Europe, or initiative by the EU member states, for instance, the 1 million sequence genomics in the EU by 2022. The Mission on Cancer could also contribute to achieving the objectives of these initiatives because the research program would promote clinical validation of the polygenic risk scores, educational activities on the clinical relevance of polygenic risk scores, and solicit public debate on their usage and control. The important aspects of our recommendation is that the proposed research program would be carried out in all member states, because we know that some member states are already engaging in these initiatives, but of course the smallest and the poorest countries cannot do that. And so to overcome existing inequity in access to cancer research and knowledge, this is going to be funded by the European Commission. And in addition, the research program would be extended to other disease areas, and such as contribute to increased understanding of other life-threatening or disabling non-communicable disease. So in other words, the cancer would be an opening access to this, which we believe is going to be expanded. I hope that that replies to your question.
Okay, thanks a lot. Thanks a lot. It really does. So it's clear that genomic data analysis will continue and accelerate in a near future. But in fact, we talk about very different data types. So I think there will be the huge blurring in what is a healthcare, what is fitness, and what is non-healthcare data in the near future. When we talk about the healthcare data, we usually talk about the data included in the patient medical records. But what if you had information about many other data, like smartphones, wearables, sensors? These all can help make healthcare better and more efficient. Now, also researchers could integrate these data to develop and to test new innovations potentially. So I would like to ask Vaiba, what are the sets of data you think we should utilize to treat and stay healthy? And would the patients benefit from using this information not included just in electronic health records, but also all the other available information like physical activity records, dietary diaries, sleep patterns, or even self-performed genetic testing like 23andMe, which is kind of you can order on mail?
This is a tough question again, but I will try to answer. I think for patients, it's very important that, like we are people, we all are people. Eventually, every one of us is a person. And I think these fun solutions that you can incorporate in your daily life that can actually help you somehow collect data that otherwise wouldn't be possible, I think we have to use them. I have been to Oulu University in Finland and saw how people develop gadgets like rings and things like that. And I think it's like a very interesting way how we can capture all the data. But on the other hand, I also think that we haven't used everything that we can from the data we already have in the systems. Like just a few months ago when I was in the ministry for a meeting and people with sparkle in the eyes are telling how after the COVID various databases will be talking to them, to each other, and the doctors will be able to get laboratory tests that are done outside the hospital. And I was like seriously? Like we have been discussing this for past 10 years and I thought it is already happening. And I had no clue that actually that is a huge dream even for the ministry, but I'm not blaming them. I understand that together with all these specialists, we will come to the solution much faster. And I also want to say here that these gadgets and everything that we can do with our phones that can be built into the various registries. For example, you mentioned cancer registries, but we also have a World Bleeding Disorders Registry in which we capture data about bleeding disorders. And that is very medical registry to which we take data from the labs and from the doctor. It takes doctors time to input data into these registries. But there are also existing many apps that we as patients can use, in which we can register, just scan the barcode of the medical, the product that we are using, scan the barcode, it goes to the, not in Latvia, of course, yet, but in Ireland and UK, they have these apps that are linked together with National Health Service, with the pharmacies, so the patient can use the treatment from the fridge, and the pharmacy is already notified that the storage is going to end soon, so they can plan deliveries and avoid shortages. So this is huge potential that we can use also in Latvia, and we are not there yet. So patients are trying to get everything they can from other countries, and I think this is something that we can, for a small country, it's not always necessary to create our own solution for something, because there are many possibilities in which we can just adapt something that is already created in other countries. And also in this era of of cooperation. For example, in the rare disease field, we have European reference networks that will become global very soon. So basically all expertise centers that are treating people with rare diseases. At the moment, there are 24 networks. Latvia is in 22 of them, and they will become global. So the patient won't be traveling to get some care. The data will be traveling without the patient. And I really hope that Latvian doctors and systems will be ready for that. And I have seen the benefits of having these CPMS and all other systems, how they help patients, and I think that that is the way forward.
Many thanks. Clearly, we are not lacking data. The only thing we lack is the information. And therefore, the question is how we make use of all that data which is generated. And conceptually, whatever way you do, but at the end you need a system which can take all of your data, whether that should be electronic health records, omics, it doesn't matter. A lot of data sources, put it somewhere, call it data lake or the other word. So you need a place where from you feed it to some analytics platform. Such approach would currently be seen as research because the concept is new, but actually the very same will be required to do the personalized medicine. We will still need it when we want to do the future clinical care, personalized clinical care. Even though if we don't have it now, we will need it to do the personalized care. So my question would go to Ain. How far do you think we are from ability to integrate various sources of data, structured and unstructured, and use them for research and also clinical decision making?
Thank you. I think a few years ago somebody said that data is the new oil. And in my opinion, if we think how the oil industry developed, so we are somewhere on the beginning of the last quarter of the 19th century, when the first attempts to refine something better out of the crude oil was discovered and then implemented at the industrial level. So the idea of real-world data and solutions to make use of that in research, but also in other areas like outcome-based payments based on the data from there. There are people and solutions that are capable of doing that a bit, but we are only learning what are the right tools and what are the right products, if you will. The example of the European reference networks of rare diseases, in my view, is a perfect one. So they didn't start from a hammer in the hand, and they didn't start debating we need a data lake. They start a very specific problem. We have patients which there are too few in one given country and in a hospital, and we need to make certain that these people get the best possible treatment. So we have to pull together data and the brain power from different sources. And I was at that time part of the eHealth network at the European Commission representing Estonia, and everybody was amazed how, regardless of all the legal hurdles and technical hurdles and data is not standardized and everything, actually it was possible to do a practical thing that helped people. So I think that we can do many things, and the idea of data lakes is one way, and certainly to analyze big data volumes. There is at least so far no better a solution to that. But at the same time, building those huge data lakes, I've seen in Estonia, it has taken now for 5 years to have everything in one place. And at the same time, on parallel tracks, very practical solutions, making use of data from health insurance fund and finding that 40% of patients with chronic obstructive pulmonary disease do not get the treatment which the guidelines are there to suggest, because for various reasons, this information either was not available to the doctors or they were just overloaded with too much of an information. So making those kind of data samples together and starting from the problem that is ahead that you want to solve, I think we can do that. And then how much you pull together a data into a data lake, how much you actually can bring the computation to the data. One solution that we are working is actually helping to strike outcome-based contracts between pharmaceutical companies and payers in Sweden, in Spain, now in UK and the Netherlands, whereby we don't build a common data lake for pharma company and insurance, because that would be very difficult to convince the people. But we take this question, how many patients with certain disease are still on treatment after 6 months and do not have the side effects, do not have progression, and at the same time have followed all the treatment guidelines, and we get back that answer. And for those simple practical solutions, there are also ways to do, and the technology is there. So yes, we can do many things.
Thanks, Hein. And one question or comment came in that actually these solutions already exist in Latvian market, and all it takes all stakeholders to sit by one table. Who and when is going to do it? I think that's an open question for organizers of this conference as a post-conference action to ensure that those stakeholders interested in the topic have an opportunity to sit at one table. But continuing on what we said and what we discussed, looking from my perspective as a hospital director, what it takes for me to leverage all of those data available. So first thing, I need to structure my data in my organization. The second thing, I need technology and partnerships. We are definitely not going to invent high-tech solution in a hospital. There are lots of tech companies who could do that for us. So in those two, I could easily solve tomorrow with enough money. But there is one I cannot solve tomorrow, and that's a question of who is going to manage it, who is going to do the job. Because everything we said so far around the data analysis in the healthcare or in a hospital is currently nobody's job. Yeah. There are no people in the health system or in hospital who can do that. So how are I going to get physicians who are high-tech literate? Yeah? I have no clue how we will attract those data genius to our teams when every industry is actually bidding for them. So we will need the new people, we will need a new different skill sets. And these are people we don't have currently in our teams. And also, we will need to figure out how we can pay for that in a current funding framework. So Emil, can you share your thoughts about, you're dealing with many young people in your different projects. So what would it take for them to join our teams in a health system and in hospitals?
Okay, so before I jump into answering the question, elaborating a little bit on the previous one, we will have a representative of FinData on the second panel. So the lady from a Finnish governmental institution who actually managed with their Citra legislation to build a FinData ecosystem to actually utilize the secondary data use for the sake of research, industrial use, and actually bring the benefit to the hospitals, also paying and covering the costs of data processing, structuring, and preparation, not analytics, which I think is quite cool. I never heard about any type of this collaboration and use case in Europe before. I will divide this in three subtopics to answer your question as a young professional. So first and foremost is connecting the dots in healthcare is an amazing job that you can do, and the thing that you should start with is the legislation framework, so basically that you can utilize the data to bring additional value. So it's not just like, hey, I need statistical data, oh, it's prohibited. Hey, I need my own data, it's prohibited. Hey, I need something else, it's also prohibited, or it's hard to get. So we should create a user or stakeholder-friendly legislation framework that allow to enter this sandbox of playing around with data, for sure, putting the privacy and ethics at the first place. So second of all, in order to bring, it's for sure money is there. You should have good reimbursement strategy to bring the best professionals there. But there is also added value that can bring to the industry, and I will focus on the second one. So the second pillar is for sure is a technological aspect. So, and it's getting back to the two previous questions. We during the conference and also in the ministry gatherings, we'll speak about creating a centralized platform, a data lake, a huge registry, cloud-based, locally based, doesn't matter. But it's very interesting because, you know, the train is gone to the next station already when we speak about not centralizing data in one place, but actually using the federated learning approach. When data stays at the hospital, like as an example of yours, data stays there because it's needed for the parents, for the children, and for the physicians, not, you know, for just statistical overview, generating insights. Because let's be open. Basically, both mine, yours, and yours data now is being somewhere and is being for sure statistically analyzed, used for any different process that we don't know about. And we should be thinking about, you know, how we can also jump into the third pillar, how we can engage individuals in generating prospective data. And this is what's bringing data scientists inside. Basically, the interest of, you know, of me saying you, like, you know, the football match. The first period finished, it's 2-1. Would you like to watch the second part of the game? And this is the same, you know, of just analyzing retrospective data and getting insights. Oh, you know, by using this treatment, this much of patient, you know, went home or went, you know, to another part of the hospital, but then you would like to understand more and more. And this is how you can create a hospital as a not a playground, it's not the correct word, but basically the framework when you can engage patients proactively, generate more data, and this is what Baiba was referring to. And the examples are there. Right now I'm sharing data with a bunch of data scientists in the University of South California via the app called Cardiogram. So basically getting my cardiovascular data right now and using this for the sake of research, for the sake of industrial project, and also informing me, hey man, we are using your data for this and that analytics. And this is an amazing thing that we can do. And this is what, you know, will turn the mindset of data science, of people who would like to work with data, because it's enormous space of opportunities there. And for sure, I'm not touching the education part because it's a very painful topic. As I'm also teaching at university, you know, and we still lack, unfortunately, the, you know, the connection between two islands of computer science or math and healthcare and life sciences, and also stakeholders like patients, governments, etc. So because we're being taught, like, you know, moving forward with programming, moving forward with treating people, moving forward with doing anything else, but not looking across the fence. And this is what we should start with. So education strategy, reimbursement policy, I will be asking a lady from FinData about that. So, and the third of all is also the way how we can provide this sandbox, both legally and technically. And I think these three pillars will engage more and more people inside.
Okay, so, well, at least there is some promise here, and we can look for those partnerships in the future. And then I would like to move to the final of the big topics, and I cannot leave it untouched, and that's artificial intelligence. And artificial intelligence is a key to analyze huge quantities of data. And it's a major driver, not only for curative, but also for a preventative healthcare. In fact, artificial intelligence is already better than human in many, many fields. So last year, I think it's February, there was a publication in Nature, and that was based on pediatric admissions in one hospital in China. 100 million data points, 1.4 million visits in 1 year. So in 1 year, the artificial intelligence proved high diagnostic accuracy across multiple organ systems that was comparable to experienced pediatrician. Not just starting pediatrician, but experienced pediatrician. And that's 1 year in one hospital in China. Imagine if it's 10 years in 100 hospitals. There's a huge potential for artificial intelligence to help physicians in decision-making and also in their probably the productivity, leaving more time for interaction with the patients. And another point is that artificial intelligence never gets worse. So it's just one-way direction, it's improvement. So we are not going to compete on China, with China on volume, but what we can do is to compete with the quality of highly curated data. So I would like to ask Walter, can we afford not to think of artificial intelligence solutions already? And is there a risk of being left behind?
Yes, there is this risk, but I think that Europe can not only be competitive, but can also lead in this field, of course, if we act promptly. In the mission board, we are really relying on the funding of this development. And I think that with almost 500 million people and some of the more advanced scientists and technology, I think we can really advance and implement, for instance, personalized medicine approaches for all cancer patients in Europe. You know, personalized medicine offers the promise of maximally effective therapies with minimal harm, both for patient and society. And there has been some efforts, but not enough. And many cancer patients still do not benefit from personalized medicine approaches. So our recommendation aims to advance, scale, implement, and optimize current personalized approaches for cancer, deepening our understanding of cancer complexity, such as the role of the host, the impact of the outer environment of cancer initiation, the evolution of cancer over time. And this is to increase the number of patients for whom effective personalized approaches can be found. But this increased precision in cancer medicine will rely on large data set for learning, as well as advanced methods and standards. And our recommendation encourages large-scale collaboration and advanced data analysis in personalized medicine. The current uptake of this is currently hampered by uncertainty about its outcomes, and in consequence, access to personalized therapies remains limited. So our recommendation will exactly going in the direction you mentioned. So there's an advancement in the methodology into outcome-based personalized medicine programs, of course building on what we have done in the past, but surpassing in its initiatives such as PERNIT with several scientists in Europe. And we would like to expand in scope to achieve optimal and person-centered care, including additional tools for personalization such as imaging, but also patient preferences and individual risk-benefit trade-offs. So I think, yes, we can do that, we have to do that, and we have to do that as soon as possible.
Okay, thanks for that. Eric, I know your organization have been also quite engaged to facilitate artificial intelligence initiatives. So can you build a little bit on what was said?
Yeah, I could do so. Yes, we have also more and more started to analyze the situation in Europe right now, and we have also published some reports of this spring. We are right now running think tank roundtables on the theme with leading experts throughout Europe to analyze and get some kind of conclusions how we could act going forward. And I think already now, of course, if we could just find the appropriate guidelines for the sharing, the usage, the curation, and how to handle person-sensitive data and so on, then with an elderly population with an increasing need of care, costs already in Sweden, I think where I'm sitting, it's 11% of GDP today. Latvia a little less maybe, but of course, if there is technology and we can use it, then we should do so, is my personal view on this. And then if we go into and look about the situation, the investment situation today, then if you look at the top 50 startup companies in the AI field today, then less than 10% of European. Seems like the EU invests less and later than US and China. It could be quality still, like you mentioned, but we invest less, and most healthcare research study using AI is done in China. But we see that the big players move in, the industry players as well, and I think there should be an opportunity, and my healthcare professionals and experts here could tell us more, but I think that the healthcare sector is still a low automation, there's not a high possibility for automation, for example. And I think that no one has to be worried that AI would take the job, since the doctors and nurses and others could meet patients. And I think today most of the AI solutions is in diagnostics, but there seems to be an increasing possibility and importance of the clinical decision making. So my answer would be, my personal view already, would be yes. As long as we have appropriate guidelines for it, then this is something one should watch carefully and invest in. And we will also collaborate and put together all the information from the roundtables around Europe within a month or now, and then I can come also with some kind of more conclusive perspective on that from EIT Health.
Okay, thanks for that. We are approaching the end of the session, so last 5 minutes for our session, and I would like to start the wrap-up conclusions. And the healthcare is changing, and like any other industry, data is starting to transform it and will transform it. Our sector slowly adopts the technologies, I would say, and the technologies which makes us better informed to make better informed decisions and improve the operations. But we need to speed this up. So at the very end, I would like another round of quick thoughts from the panelists. Please suggest 1 or 2 key immediate actions to make data serve better for patients and also to serve sooner for patients. So again, I'll start with lady.
Okay, so I think the first and most important thing is that we should recognize patient organization definition not only nationally but also in Europe, and involve us formally in many things that are happening, like projects and everything. And locally, I think, like you suggested, we can come all together and decide how to move forward. And I think that would benefit the patients at most.
Okay, thanks for that. Emil?
So we speak about 2 action points in Latvia, am I right?
Yeah, well,
Not worldwide.
that's
Okay.
more actionable.
Okay. Yeah, apart from Baiba mentioned that we should not only recognize the stakeholder, but communicate. So the communication, once again, I think this is the core thing that we touched base during all of the discussions, presentations today.
So building the continuous platforms.
It's basically sitting down together virtually in face-to-face and actually, you know, understanding the value proposition, why people will elaborate on creation of such a system. Not just, you know, top-down approach when governments say, hey, this is a new EHR, you should use this, everyone. And basically, stakeholders lack motivation, lack added value from that. So communication, the first part. And the second part is, I think, is apart from structure and data, which is one point B point, and structure and data in the right place. It's not about IT system that we should buy, procure, build. It's about rightly and well-established data structuring among various institutions in Latvia. And using the standards from abroad, not building our own standard. It wasn't in a part of the discussions last year. It's a crazy idea. And the second and the last is right legislation. Basically, I would form it in one sentence: attractive legislation for industry and scientific community to come in Latvia, from abroad and also inside Latvia, by putting the privacy and ethics at the first part, but not just, you know, using data and stating, hey, we have a data lake, we'll use the data for the sake of something. I'm here, I would like to benefit from that. It's not like, you know, I would like NHS to benefit from that. As a patient, I would like to benefit from that now. So I need to be engaged there. So right legislation, putting the privacy and engaging me as an individual there in the process. I think this is it.
Thanks for that. Walter, your thoughts?
I think removing the legal barriers to sharing data at European level is the first. Without that, we cannot go forward. And the second is to promote a cultural change among all stakeholders, but this has to be done in a structured way, not on a voluntary basis. It has to be organized in a way that somebody is accountable, that there are key performance indicators, and that in the shorter term we can achieve this, because otherwise there is going to be resistance to change and the health sectors will continue to lag behind.
Thank you. Eric?
To complement what others have said already, I would also turn to medical and faculties, and or whether it's the Faculty of Science and Technologies, to think about what was earlier mentioned as middle medical persons, physical extenders, because there is a lead time of 3 to 5 years, I guess, to educate what is needed tomorrow to compile with this. So that would be another talent attraction and education for physician extenders, whatever the definition is.
Thanks a lot. And last but not least, Ain.
Yeah, thank you. I have basically one suggestion. So pick a problem and start finding solutions using data. Do not start from a feasibility study. If the data is available, what is the quality of the data? Let the problem lead you to the data that you have, and let the practical work let you to improve the data as you go. And for a start, I think Baiba in the very early intervention said that first, let's start counting not how many procedures we do, but how many people we have helped and how much. A simple thing, very practical, start immediately, and it will deliver a lot of value and bring all the rest, what we discussed here, AI and everything, along with it.
Okay, thanks for that. So on a final conclusion, the intention of this section was not really to deep dive, but rather we uncovered just part of the questions around the value of the data in the healthcare, and specifically for the benefit of patients. So in order to leverage value of data for a patient benefit, we need to act. Yeah, that's what I heard. And invest. And invest with a confidence. So we need to do at least three things. To build the robust data infrastructures. That's what I heard. Establish efficient collaborations and partnerships to attract technologies. And finally, to develop the skills and attract new skill sets in healthcare. That's a roadmap, and there is much at stake, and we don't have other options than to act. So many thanks for my panelists for a fantastic contribution and your thoughts. And by this, we're closing. Good luck and goodbye.
All right, thank you very much, panelists. And Wout, if you could stay here for just one moment. Yes, thanks to the panelists here. We have one question from the audience watching at home, and it's maybe a question that you can or cannot answer. Let's see. But the question is, many of the solutions that were mentioned today already exist here in Latvia. All it takes is all stakeholders by one table. Who and when is going to do it?
So we try to address it, and as I said, so I believe it should be like an action plan or a follow-up after that conference. So there should be like a common agreement or the things we kind of paint as a roadmap after the conference. And clearly that communication, which was many times emphasized by Eric, by Emil, so building those collaborations very practically, start conversations and start from one common task. I think that's a way how to do it.
Who do you think should be the person leading this or the person responsible for this? Or maybe an institution?
I think you cannot mandate innovation. You cannot like put it from the top. I think it needs to emerge. And that's why I said, I emphasize the importance of those people interested in the topic who are willing to drive that, and the necessity to provide those opportunities. So I think it's emerging from within, and we just need to help that.
Yes, thank you very much. All right, and this also